everyone. Welcome to another OD-Wire webinar. It's Adam Sparkus here, and we've got an action-packed webinar tonight that's going to take up all of our time. So very briefly, with some housekeeping, if you have questions tonight, use the question box as usual. Our raffle this week was for an Apple TV. Again, check the thread where this webinar will be posted when all is said and done to see if you won. And with that said, let me introduce our speaker tonight. We're honored actually tonight to have Dr. Jerome Sherman. And I don't even think I need to introduce him. He's probably the most prolific writer in eye care. He's published at least 650 articles, numerous books. And tonight he's going to be here to teach you all about how to read an OCT image. So he's got a lot of information to share. And so why don't I just turn things on over, and Dr. Sherman, here we go. Let me turn your mouth on.
Well, thank you very much, Adam. Let's see if I can get this to work.
There we go. Hang on. Let me get you going here.
Okay.
Okay.
I assume everybody can hear me, at least if no, I don't have control. So yes, we're going to be chatting about OCTs this evening and a lot of the clinical applications of OCTs. And it looks like I may have an active mouse now. Okay, this is actually a website that some of you may or may not know about. It's called the Retina Revealed, www.retinarevealed.com, upper left corner. And we already have over 1,000 OCTs on this website with about 800 other images. And this is completely free. Everything's set up under an archive system where there are lots of different cases. And we'll make reference to this as we go through this evening. Okay, Helmholtz. Our friend Helmholtz, about 150 years ago, invented the ophthalmoscope, and it's worked great for 150 years, and most of us still use it. But in reality, when you compare an exam with an ophthalmoscope to what's going on with OCTs, we find out there's a lot that we actually do miss. There are a ton of disorders that are invisible to ophthalmoscopy. So we are going to spend time with spectral domain OCTs. You can't buy a bad one. The 6 that we have here, I've used, and I find they all work really well. The one that we're going to spend most time with tonight, or at least most of the images tonight, will be from the 3D OCT 2000, the TopCon. A couple of reasons. One, they're the sponsor, and two, it actually is the only system that allows us to take fundus photos simultaneously. So that's actually very, very helpful. Here's a normal OCT, high resolution. Let's just give you the next one, which is labeled. So this is a foveal pit right here. Under the foveal pit are lots of tissue, but the most important tissue under the foveal pit is this line right over here that we call the PIL, the photoreceptor integrity line. That line highly correlates with visual acuity. So the photoreceptors take up about half of the retina, if you look at all the different layers here. The ganglion cells and nerve fibrillary are on the surface, if you will. And down here is really what's associated with visual acuity. I can find my arrow. I lost my blue. Okay, here we go. Looks like we got it. Okay, on the left is a histological section. On the right is a standard run-of-the-mill OCT through the fovea. This is using one of the first TopCon systems. And what we've noticed early on is that all normal patients have what we call a PIL, a photoreceptor integrity line. It's not really visible histologically. But it does correspond to the junction of the inner and outer segments of the photoreceptors. It shows up very, very well on OCT because of the different index in refraction between the inner and outer segments. Below that, we can see a thicker and less well-defined retinal pigment epithelium. So when we talk about macular disease, the PIL and the RPE are two of the most important structures. Still having trouble finding my blue arrow. It's somewhere in here. It's important to recognize the population of rods and cones. Osterberg, many, many years ago, before World War II, actually counted rods and cones and showed us that cone concentration is extremely high right at the fovea and then drops off remarkably rapidly. Whereas rod population, there aren't any rods right in the fovea, and rod population increases rapidly as you go away from the center of the fovea. This below is an OCT, which is a 6 millimeter section. It turns out that if you do some of the simple calculations, the highest percentage of cones, or at least the high concentration of cones, are within an area which is about 1 millimeter across. So that PIL line tells us about cones here But as soon as we get out to about this section, it starts to tell us about rods. So this patient has rods and cones. So the rods are out here, the rods are out here, and the cones are really here. Of course, there are some cones in the periphery, but really in such a small number that it's not really all clear. Adam, I still don't see my blue arrow, but that's okay, if you can do it for me.
Sure.
There are lots of pathologies that are invisible to ophthalmoscopy. We can look at that from the inner retina to the middle retina to the outer retina. For example, in the inner retina, we often have trouble seeing the retinal nerve fiber layer. We never see the ganglion cells or the ganglion cell complex. We most often miss things like vitreal macular traction with an ophthalmoscope. In the middle of the retina, we certainly can see some exudates, but as I'll show you a little bit later, we only pick up about 5 to 10% of exudates with an ophthalmoscope. We see far more with spectral domain OCT. Retinoschisis, or splits in the center of the retina, those are very common in the macula and around the optic nerve in myopes, and yet we don't see them clinically. In the outer retina, we have the PIL, the photoreceptor integrity line. Now, Helmholtz never saw a rod or a cone, and we don't do that clinically. So we don't talk to patients on a daily basis and say, Mrs. Jones, I'm going to look at your rods and cones today. Of interest, you can look at the rods and cones, at least indirectly, because we now have what we consider to be a biomarker for photoreceptor integrity. Early drusen, early choroidal neovascularization, and early macular holes are also pretty much invisible to ophthalmoscopy. Here we have an interesting image. Now, if you just remember what we said before about cones, this line over here, that's the photoreceptor integrity line. And right over here in the central 1 millimeter or so, it seems to be missing. The line above it is the external limiting membrane, the ELM, which isn't really too important clinically for very many reasons. But the PIL, the photoreceptor line, is certainly important. Below that, we have the retinal pigment epithelium. So if you remember the statement that I made before, that the central 1 millimeter really contains, all the cones, or many, many of the cones. This patient looks as if they have very few cones. We can look at case 1, dramatic reduction in cones centrally. Case 2, similar image. These are horizontal slices, but we can take vertical slices also. Vertical slice shows something a little bit different. Case 3, again, we're getting the same thing, at least in this eye. Here it looks like the PIL is missing, and we have the external limiting membrane, which is sort of collapsing towards the retinal pigment epithelium. And yet another case, and still a case after that. Okay, so what do you think these patients have in common? What these patients have in common is a dramatic decrease or maybe complete absence of cones. And these patients are actually rod monochromats. So they have rods, but they don't have cones. And they also have virtually no color vision. So is this sign, if you will, pathognomonic? Meaning, are there any other diseases that give us a sign? It turns out that it's pretty close to pathognomonic, which means we virtually never see this in any other disorder. Perhaps 1 in 300 patients with Stargardt's we see it. And you'll see a couple of others that are sort of close to it, but not quite like this. So if you have a patient with reduced acuity, maybe subtle nystagmus, and reduced color vision, and you find this on an OCT, this is pretty much a diagnosis of the patient having achromatopsia or rod monochromatism. And it really is very close to being pathognomonic. Out of the cases we've looked at about 15 thus far. 1 or 2 give something a little bit different, and maybe the diagnosis is actually wrong. Over here we can see a PIL, but then everything sort of disappears. This patient either has achromatopsia or has some type of cone dystrophy. Again, as we look at the central part of the retina under the foveal pit, everything is attenuated, tissue is thin, but the PIL, the photoreceptors, are missing. Let's go back and go forward. I'm still having trouble finding that arrow for some reason. It sort of disappears on me. We can do ERGs on these patients, and as you would anticipate, scotopic ERGs that tell us about the rod should be normal, but as we then do cone ERGs, with a bright light and a well-lit stimulus, if the patient doesn't have cones, you'd expect pretty much a flat response. And that's what we're getting here, pretty much a flat response. So this is actually a way of, in a sense, confirming the diagnosis. We also have a technique called multifocal ERGs. Normal multifocal ERGs are over here. This corresponds to the foveal pit and the macula area. Again, this is a functional test and not a structural test with OCT. An achromat, or patients with significant cone abnormalities like a cone dystrophy, would have something like this. It would be very, very reduced. And you can see the color blue means it's a reduced response. Again, that's function and not structure. So in this instance, we really have function and structure that relate pretty well. Here's another patient which has something that looks a little bit similar right under the foveal pit. Looks like there's tissue missing. Looks like there's a sort of a well-defined, well-delineated rectangular hyperreflective space, as you can see here. It looks a little bit smaller, and it looks like it goes a little bit deeper, interestingly enough, than the one we just saw. Above, we have a typical achromat, or rod monochromat. Below, we have a patient with a different condition, although there are some similarities. Certainly, the PIL is missing in both, but for a smaller area. And down here, we're looking at the retinal pigment epithelium. And the RPE, which is only a single layer of cells, actually sometimes looks like a triple layer. So that there's a reflection off the inner part of the retinal pigment epithelial cells, the outer part, and then we get something in between. So what we're missing here is really the inner part, or the inner reflection of the retinal pigment epithelium. That we sort of call, that's called Verhof's membrane in some of the literature. That patient has a known problem because we have a good history. This patient has solar retinopathy. Acuity is down to about 20/60. Most achromats, complete achromats, have acuity of 2200 to 2400. 2200 is the most common, and they have virtually no color vision. Solar retinopathy patients usually have better vision, and they do have some color vision because they still have cones outside the central small area that's missing, which could be maybe 100 microns across. So one of the few things that looks like achromatopsia is solar retinopathy. And that's important to keep in mind. But a history and some other information will usually give us a diagnosis. In a typical scan, this is the foveal pit again. We have the PIL. The PIL should go all the way across. And this is a 6 millimeter scan. As you can see, it goes all the way across. In this instance, you might see that the retinal pigment epithelium actually looks like it has 3 layers, sort of down here. Okay? So we talked about what happens when the cones are missing in the central 1 millimeter or so of the 6 millimeter section. What happens when the central part is present? Here we're just looking at it in color. Grayscale sometimes, but not always, gives us more information, so it's good to flip back and forth between color and grayscale. In this instance, we see a foveal pit, we see a PIL, a photoreceptor integrity line, and then the PIL seems to disappear, it seems to fade away. Now that's interesting because if we go back to the Osterberg curve, this is where the cones are, you know, the highest concentration of cones, and there are very few cones outside of this area. So then we go into a zone where we have entirely rods, so pretty much entirely rods, mostly rods. So this patient looks like the cones are intact, and the patient does have 20/20 acuity and normal color vision, but the rods seem to be missing. What might you think this patient has? Well, there's the PIL. It sort of ends where we've shown it. The retinal pigment epithelium is still present with that red arrow over to the left, but we are missing tissue. You may look at the disc and the retina. You may see an attenuated arteriole. Maybe the disc looks ever so slightly pale, but usually it doesn't. Here's a normal control for comparison to show you that the PIL really should extend all the way through the 6 millimeter slice. In this case, it obviously doesn't. So this patient has a problem with rods, and pretty much at this stage, not a problem with cones. This is fairly typical of a patient with retinitis pigmentosa and normal central visual acuity. This case may progress to affect the central retina, but at this point the patient has a normal central field and normal visual acuity, and does have color vision that's fairly normal. Notice the normal patient below with a PIL that's intact outside of the fovea, and notice the patient with retinitis pigmentosa, where you can see the PIL is completely missing. So you could make a diagnosis of retinitis pigmentosa just by understanding how to interpret the OCT. You could confirm it with an electroretinogram, as we mentioned before, and the ERG will be flat under the scotopic or rod conditions, but will probably still be present somewhat under the photopic conditions because there are cones present centrally. Here's a patient with 20/15 acuity. He happens to be an attorney, and he came in with a chief complaint of difficulty playing ping pong. He used to be great, and now he says he's getting really bad. He doesn't understand it. Well, we look at his fundus and we say it doesn't look quite perfect. Maybe there's some thinning here. Maybe some subtle pigmentary changes. But we look at his OCT, and we can see that it looks pretty normal in the central part of the retina, central millimeter or so. His cones are okay, and he has normal central acuity. And the same is true in the left eye. But as we go out a bit, the PIL just sort of fades away. So that tells us that the PIL is missing in what we usually consider to be rod territory. We can take another image of this, a vertical one. I guess we can go back here. And here we can see, again, it's a vertical slice right through the fovea, vertical section. We can see the PIL is present under the foveal pit in the right eye. PIL is present over here under the foveal pit in the left eye, but then it just disappears. It just sort of like fades away. This patient has pretty much intact cones and virtually no rods, very, very few rods. And this is actually a form of retinitis pigmentosa. This is sort of like a pericentral retinitis pigmentosa. We actually know the gene and stuff, and it's it's an autosomal dominant, runs in the family. Here's another slice in this patient. So as soon as you get outside of the fovea, over here we're certainly outside the fovea, the retinal pigment epithelium is still intact, but the PIL, photoreceptor integrity line, is missing in rod territory. Same is true in the left eye. Here's the macula, here's the slice, and we're missing that line. That line is pretty much nowhere to be found. And this, again, can help you make a diagnosis of retinitis pigmentosa with or without an electroretinogram. ERGs can confirm it, but are probably not essential anymore as they were in the past to make some of these diagnoses. Here we're getting a section. By the way, these boxes are 6 by 6 millimeters. We typically take 128 horizontal sections through it. Here we're looking at this section above the macula, the same right eye section below the macula, and we can see that the PIL is really gone. We're getting the retinal pigment epithelium, but we're not getting that line above it. Well, again, we are in rod territory. As soon as you get outside of the central 1 millimeter or so, right about over here outside the macula area, we really have very, very few cones, and this patient really has no rods, or very, very few rods and very few cones in that area. Although, as we showed you before, there is a PIL that is present centrally because that's corresponding to the population of cones. It's fairly normal. Here's another patient who's a little bit more progressed. Acuity here is starting to drop to about 20/30. We can see there's certainly more tissue centrally. So the PIL is present, but it's not fully normal. It's starting to collapse itself onto the retinal pigment epithelium. But as you go out a little bit, half a millimeter or so, we can see the PIL pretty much disappears. This is typical for retinitis pigmentosa as it progresses. We do sometimes see retinal degenerations where there's no PIL anyplace, and we've seen that as young as patients at age 5. So here's RP with good central acuity. These images exist on Retina Revealed, by the way. Here, right through the fovea of this patient, we can see that there's a PIL present, but then it fades. The retinal pigment epithelium is right under the PIL. As we take a slice superiorly to the macula, we see the RPE, but the line above it is pretty much missing. When we take a slice in this right eye below the macula, we can see that the retinal pigment epithelium is present, but we're not really getting that other line, which corresponds to the photoreceptor integrity. This is a little bit further out. We're now seeing something a little bit unusual. What might that be? Turns out that's pigment, and pigment migrates in retinitis pigmentosa. We can show that because we can actually look at the TopCon image and compare it. So we're getting fundus photography done at the same time as OCT, and we can go back and forth between them. So right over here, higher mag, we can see some pigment. That's the slice we have. So pigment's usually down here, of course, in the outer retina, where the retinal pigment epithelium is supposed to be. But retinitis pigmentosa, we often get pigment that migrates to blood vessels. The blood vessels are actually within the retinal nerve fiber layer, which is a superficial retina, or the inner retina. And here we're getting pigment migrating. We can actually show that, and we've shown this in many, many cases. So pigment in retinitis pigmentosa, and in some other disorders, actually does migrate from the outer retina to the inner retina, and often wraps itself around blood vessels, the bone corpuscle type pigmentation. Somewhere in here is a blue dot. Blue arrow, there it goes. Okay, so there we are, retinal vessels, usually not apparent with OCT, but here when we have pigment wrapped around them, we can actually see them. Next case. Well, something is going on here. Let's again look at the PIL. We're at the fovea in both eyes. PIL is present over here. And then it's poorly, it's poorly defined, and then it sort of disappears. Comes back over here, and comes back over here. In the other eye, in the left eye, we can see that there's really no PIL present here. It's disorganized here. It's disorganized here. Here it's present, but poorly formed, and here it's present, and not very well formed. If I told you that the acuity in the right eye here was 20/25, you would probably believe me because the PIL is intact. to some extent. And if I told you acuity in the left eye was 2200, you would probably believe that too. If I told you this patient had a toxicity, you might come up with a diagnosis. And this patient's been on Plaquenil for over 10 years and has Plaquenil retinopathy, early Plaquenil toxicity. And this is in Retina Revealed number 2 if you want to go into details about the case. And it turns out that spectral domain OCT is very useful to show early abnormalities at the level of the retinal pigment epithelium and photoreceptors. By the way, you might remember that Plaquenil gives us a bullseye, so this is one slice, but the tissue that's most abnormal is right over here and right over here. And if you did that in 360 degrees, you would be able to visualize bullseye presence. So the central retina is a little bit more normal than the perifoveal area, which actually loses tissue, loses pigment, and actually loses photoreceptors. Hence, we sometimes get these little tiny, defects, little circular-type defects in the central, corresponding to the central retina. So this is one of the procedures that's very helpful in the early diagnosis of Plaquenil toxicity. Multifocal ERGs are actually the single best test we have, but these are very hard to find. Very few people do these. I do these at the university at SUNY, and it's a great test. 103 little zones are actually hexagons, pattern reverse in a pseudo-random fashion. Then we get information from 103 parts of the retina. Turns out that most of the studies are suggesting that multifocal ERGs are the single most sensitive way of picking up Plaquenil toxicity. But spectral domain OCT, which are sort of widespread, are also very, very good. Here's the next case. Oh, let's go back one. I don't know where my blue is. We have a sense of where it is. Oh, it's all the way in that corner. Okay, let's go back just one more. Okay, what do we have here? Well, we have a patient. We have a whole series of patients with funny dots. This is the differential diagnosis of white dots and spots. So we have some exudates. We have some cotton wool spots over here. We have edema residues here, if you blow that up, which you can actually see little tiny dots. We have drusen, which are very common, Stargardt's disease. We have punctate endochordopathy, fundus albi, and Bietti's. Some of these are common, some of these are rare. But OCT can virtually help you make the diagnosis in every single case of a white dot and spot. We have a paper coming out on this. It's actually on a journal called Eye and Brain, which is a free journal where we go through all of this at some point in time. Well, here's an OCT. What are we getting here? Well, here's the retinal pigment epithelium. Okay? So all the rest of this is the neurosensory retina. So we're getting a clear fluid with serous detachment of the neurosensory retina. We're also getting something going on over here. It looks like there's a little PED. Here's the retinal pigment epithelium. So that's detached a little bit or elevated. So pigment epithelial detachment and a much larger neurosensory retinal detachment. And there we can see the PED, and that's can't really see much in the fundus image, which is actually an infrared image. Let's go a little bit further. How about those little tiny dots that we sometimes see as edema residues in patients with central serous? This is actually central serous. Central serous, by definition, is a detachment of the pigment epithelium, PED, and then a larger detachment of the overlying neurosensory retina. Typically, remember the photoreceptors are over here. Now the photoreceptors are separated from the retinal pigment epithelium. In a normal state, the retinal pigment epithelium phagocytizes the debris created, the discs, which are shed by the outer segments of the photoreceptors. But since there's a distance now between the retinal pigment epithelium and the neurosensory retina, they accumulate. And they're sort of like edema residues or retinal precipitates, if you will. This patient is showing a leakage on fluorescein. This is now central serous. And those dots are very typical, and it's the only condition where we really get the dots on the lower aspect of the neurosensory retina in a neurosensory retinal detachment. Here are some more of them. Okay, so these are, again, edema residues or retinal precipitates, if you will, really the same, they mean the same thing. And when you see this ophthalmoscopically, what you may just see are little dots in the macula, and you have no idea at what level they are. But now we know, based on OCT, that they're actually at the level of the photoreceptors, which, again, because the neurosensory retina is separated from the retinal pigment epithelium. That's helpful in the differential diagnosis of little dots and spots. Going back to at least these 9, Bietti's, which is a very interesting condition right here, if you will. And Bietti's is a crystalline deposit, crystalline deposits in the cornea and in the retina, named in 1937 by Bietti. And interesting disorder, we cover it in Retina Revealed number 15 in some detail. These patients can have very severe degeneration, and you can see the retina looks very attenuated here. But one of the things that we see in a lot of degenerated retinas, which we've never seen histopathologically under a microscope, is something called an ORT, outer retinal tubulations. These are not blood vessels. These are actually tubes that are created, we think, by Macular cells that are trying to regrow the retina. This very thin band over here is Bruch's membrane. Now, I haven't mentioned very much about Bruch's membrane yet, because Bruch's membrane is actually the lower part of the retinal pigment epithelium, but typically we don't see Bruch's membrane. We start to see there's a very thin Bruch's membrane, which is very well defined. It's only 1 to 4 microns thick, but as you lose RPE, Bruch's membrane is unmasked because of the overlying loss of tissue in the RPE. There it is, Bruch's membrane. So this patient has a retinal degeneration. There are also crystalline deposits in the cornea and in the retina, and those are at that level, pretty much. As we can see, they're quite deep. That's what the fundus looks like. And this is like a patient presents sort of like retinitis pigmentosa, where they have night vision problems, they have central acuity loss, they have color vision loss, but they really have lots of trouble seeing at night, in a general sense. The cross-sectional images are on the right, but we can also take not only cross-sectional images, but we can take images as if you're doing a fundus photography, but actually do it with OCT. And that's what we're doing here. This is called an en face image, sort of looking en face directly at the face of the OCT. Rather than slicing through 10 layers, or 11 layers when they're all intact with the PIL, we actually just pick out 1 layer. So this is actually at the level where the PIL should be. And we can see we're getting these little tubes. Let's try to correlate this. So we can actually go from the sections, from the cross-sections, to the en face image. So that one over there, that sort of like round, body, whatever that is, corresponds to this one here. And this green one corresponds to that one. And you can see on the en face images, they're not really round, they're actually tubular in shape. So these are called ORTs, outer retinal tubulations. First talked about at a lecture by Bailey Frond. This case is in Retina Revealed. I was the first to publish it, but I gave Bailey credit because I actually learned it from him. His article came out a little bit later. And I suggested that we call it FORT, outer retinal tubulations, but forts instead of orts for Bailey Frond, for Frond. And he was very happy with that. And if you look at Retina Revealed, you'll see a picture of Bailey. So here it is, a normal patient on the right and a patient who has these outer retinal tubulations. We see them in Bietes. As you know, all retinal degenerations sometimes show them, but we also see them in common conditions like macular degeneration. So they're really common, and you're going to start to see them, and you're going to wonder what the heck are they when you look at them in cross-sections. When you look at them in cross-sections, they look like almost like blood vessels deep in the retina, but they're not. And when we look at them in a en face image, they're actually going to have more of a tubular shape. So it's something to keep in mind and hopefully not confuse you. So here's a patient with Bietes, as you can see, the left eye. A lot of the tissue is gone. We could label it here, and we can show you the 2 outer retinal tubulations, which in cross-section look round, but again, on the en face image, they don't look round at all. And we can see Bruch's membrane. Why Bruch's membrane? Because the retinal pigment epithelium is pretty much gone, as is the PIL, the photoreceptor integrity. These patients have very reduced acuity and very reduced visual fields, essentially not measurable visual fields. You are going to get some crystalline deposits, as we showed you. I think I went through that a little too fast. There we go. And we do get some crystalline deposits. They could be at different levels. And we do get them in the cornea also, in Bietes. So here's a normal patient and a Bietes patient. You can see that the normal patient has a thicker retina. The biggest change is in the outer retina, not in the inner retina. It still is neurofibrillary here, which is right over here. This is neurofibrillary, by the way. Okay. This, by the way, is a posterior hyaloid, which is detached here and attached to the macula and then detached a little bit. That's an extremely common finding. By the way, the PIL, when it blips up a little bit, towards the foveal pit, that's normal because the outer segments of the photoreceptors under the fovea are actually longer than any place else. So that little blip in the macula is okay. But again, this patient has Bruch's membrane, and retinal pigment epithelium above it is gone and the PIL is gone. So you can clearly see a major difference between a normal individual and a patient with one of these fairly severe retinal degenerations. How about this one? Well, it looks like the PIL is missing over here. PIL is present over here, missing here, Looks like the internal living membrane is still intact. Let's get a better image of that, maybe in a different case. So the ileum is still present. There's the fundus, if you want to look at the fundus. Fundus has maybe some slightly abnormal venules very close to the fovea. This is actually called macular telangiectasia type 2, or a MAC-TEL is a term that's now utilized. And what it looks like, it does have an inheritance pattern, but it's not really well understood. It's an interesting disorder. It's sometimes hard to detect ophthalmoscopically, usually in young to middle-aged patients. It usually affects both eyes, one more than the other. Typically, we're losing tissue, as you can see here. But the internal living membrane is still intact. So this pattern of tissue loss in the macula, PIL present over here outside of the macula, PIL present here outside of the macula, but missing here. So you are seeing retinal pigment epithelium. But obviously, there's lots of tissue missing. Here's the right eye and the left eye of this patient. And with the draping, if you will, that's a term that's usually used. The draping of the internal membrane can actually come all the way down. This is close to being pathognomonic, not quite pathognomonic, but very typical of patients that have MAC-TEL 2, classification 2. Here's another one, again with draping. We'll go back one more time. Draping of the internal membrane right over this area with this tissue missing. No real effective treatment. There are a bunch of studies going on. If you have type 1 of MAC-TEL, usually there's an exudative reaction that is treatable, but type 2 doesn't seem to be treatable at the present time. At least there's no published treatment that seems to be successful. Okay, let's change gears completely and go into another patient with a completely different condition. We'll look at it in color, then in grayscale. Then we'll look at the fundus. We can see this patient has lots of exudation all the way around, actually nasal to the disc and, of course, temporal to the disc. The slice that we're taking is right over here, 2 slices very close together. And we're getting this, which is very interesting. This is what I'm trying to bring to your attention. And it's sort of a round or an oval body. Here it looks fairly round because I have a 1-to-1 magnification here. So it's really something strange. It's a little bit like that tube that we talked about before. But this actually could be a blood vessel. And we'll show you why that could be a blood vessel. Well, we did a fluorescein. And this patient has lots of leakage, lots of exudates, of course. And this is an artery. This is actually a dilation of an artery. So that is a macroaneurysm, if you will. Here's another artery. Here's another dilation of an artery, another macroaneurysm. So these are known macroaneurysms on fluorescein. And you can get them in cross-sectional analysis with OCT, as shown here. And what they have, they're really these, hypo-reflective oval or round bodies, but they have a hyper-reflective border. So here's a hyper-reflective border. So the border is reflecting, but that's actually the vessel wall itself. Now, if you're not convinced, you probably can be convinced when we put everything together. So there's what we think is a macroaneurysm. We could match it up with the fundus image over here. That's exactly where we're looking. And match that up with an area on fluorescein where it looks like there's a vessel that's actually very, very dilated, like an aneurysmal dilatation of a vessel. It stains extremely well. And there are these 3 red arrows pointing to the same exact spot. So this is indeed a macroaneurysm. Macroaneurysms are usually associated with hypertension, systemic hypertension. And you can have more than one in one eye. And if you happen to have significant high blood pressure and develop these in the eye, there's a heck of a good chance you can develop these in the brain. Rarely are they associated with, are they idiopathic, meaning you can't find anything systemically. This patient has severe hypertension. So in this instance, the diagnosis is quite simple because we had the appropriate systemic disorder. In contrast, we're getting something a little bit different here. This patient just had retinal detachment surgery and had one of the various oils in the eye, silicone oil, a bunch of different gases and oils that are used in various types of retinal detachment surgery. And somebody noticed this and we just took a slice through it. So this is actually gas. It could be oil, but this is actually a gas that was injected into the eye. And you can see it's a, it's sort of round. It's hypo-reflective, but it doesn't have a hyper-reflective border. It doesn't sort of have a border around it. So it's just, it's not like a blood vessel, if you will. So the differential diagnosis of a macroaneurysm will include very, very few things. But one of the things that it will include is something that you will find on rare occasion after a patient has had actually retinal detachment surgery, where there may have been some gas or even oil that was left behind that somehow got into the retina. It doesn't really represent a major problem. In the same patient with hypertension, okay, the patient has all sorts of macular cysts. This is now going through the macula. The slices before we're not going through the macula. And here we see these multiple areas of cystoid spaces, if you will, but these two do not exhibit a hyper reflective border. You know, it's just sort of spaces, but it's not round. It's not a blood vessel clearly, and it doesn't have a well-defined hyper reflective border. So that's fairly typical of macular cysts in a lot of different conditions. We can get that in diabetes and hypertension, of course, in vein occlusions. So that's a relatively common pattern. This looks a little bit like it, but is actually not nearly as common and looks a little bit different, but you have to consider it in differential diagnosis. Here's a normal for comparison. And this patient has a condition called X-linked retinal schisis. In this specific case, it wasn't an obvious diagnosis. These typically affect little boys, ages 4 or 5 or 6, when you start to get reduced acuity, maybe 20/60 or so, typically in both eyes. If you do an OCT, you get this pattern. So that's X-linked retinal schisis. The electroretinogram, if you have one available, is going to be an electron-negative wave. There seems to be a problem in the Mueller cells, and this is about the only condition where we actually talk about a problem in Mueller cells within the retina. I'll show you another example of this here. So these are central splits in a retina associated with a condition which is inherited, sort of a retinal degeneration, X-linked retinal schisis. There's a vertical slice. We'll show you a younger patient coming up. Here's the same vertical slice in another patient. Here's a patient where you may see something clinically. You might see some radiating folds right over here in the macula. If you look really, really carefully. I'm not sure what kind of monitor everybody has, but you might see those, and I think we have another example of that. So these are these radiating patterns. That's what it looks like. If you see anything, that's what you'll see in the macula, these patients with X-linked retinal schisis. So the retina is actually split, multiple splits within the retina itself. And another slice, another section. And that one, if you look really carefully, you probably can see the radiating folds here. Sometimes you see them, sometimes you don't. When you see them, it's a much simpler diagnosis. When you don't, you have to go to spectrum and OCT and maybe ERGs. Now, that's a central schisis, schisis in the macula, which is fairly rare. X-linked retinal schisis is not a common problem. But schisis in the mid or far periphery is far more common. About 1 to 4% actually have peripheral retinal schisis, or senile schisis. And there are times when we actually do want to get an OCT outside of the macula and try to get some sense of what's actually going on. So here we have a vertical section, as you can see, and we're showing it over here. So the part below, from, say, this blue line going across here, this part below, that's a schisis. That's a split within the retina. You may get a split in the inner plexiform layer or the outer plexiform layer. Both are possible at the same time. Over here, above that, it looks like we have an intact inner retina, but it looks like the outer retina tissue is missing. So if you look at this, that corresponds to this section here, and this is a circle. That is an outer retinal hole that we're looking at. In an outer retinal hole, we're not going to have any outer retinal tissue, as we see here. When we go into the area of just the schisis, there is an outer retina, and there is an inner retina, but the inner retina is split from the outer retina. But here we have just an inner retina and no outer retina. Sort of interesting. So that's a retinal schisis, and knows that that's an outer retinal hole. This is, the question is, does this patient have a retinal, what does the patient actually have? There are a couple of possibilities. So we do have these outer retinal holes, and we do have that area of schisis. Let's go a little bit further, and we can look at this. This is actually an OptoMap image. And the outline of the entire schisis is shown with the blue dots. The outline of the 5 retinal holes, outer retinal holes that we see are shown. Patients with outer retinal holes by themselves, without inner retinal holes, typically don't have to be treated. They can just be followed. And they certainly can progress. 1 in about 350 patients with schisis, peripheral schisis, develops a retinal detachment, only about 1 in 350. So this almost never spreads into macula. This patient, by the way, has dysdrusen, I'm going to talk about later, and has macular drusen as well. Macular drusen and dysdrusen are unrelated, and also unrelated to the peripheral schisis, which again can occur in 1 to 4% of the population. The question that I was going to ask before, it looks like one slide got moved, but here's 2 slices in one eye. Is it a retinal schisis or a retinal detachment? These are 2 horizontal sections in the peripheral retina of the same patient. So one of them, the upper one, corresponds to a slice over here. This lower section corresponds to a slice about over here. So there's one elevation here with black arrows and another elevation here. Turns out the one below is actually a retinal schisis. This looks fairly much like a schisis, with dots on the surface, which are probably just, part of the schisis process, which is not at all unusual. We see that often. And here, it looks like the retina is actually split apart. Notice that this is a very, very thin membrane relative to the one above. So the slice that's going through here is actually 9 layers of the neurosensory retina separated from the retinal pigment epithelium. That's a true retinal detachment. Here, we're getting a much thinner retina. Why? Because a lot of the retina is actually left behind. The resolution here is certainly poorer than we're typically going to see because we're really far out in the peripheral retina. So you can get OCTs further out. We just do lose, if you look at where it says this is between the aura and the equator, and we can get horizontal and vertical slices. So this is a retinal schisis. Little dots are just surface degeneration. This is actually a frank retinal detachment. So this is a retinal schisis present in about 1 to 4% of patients, and a retinal attachment associated with schisis, only about 1 in 300 patients with a retinal schisis. Rarely do they have to be treated. This patient happens to be an optometrist and he's asymptomatic. We've looked at him carefully he has been looked at carefully over the last several years. I've only seen him once. He's from down south, and he has not changed. So retinal schisis, retinal detachment. Here we get closer to the central retina. This patient has a macular lesion that we're not going to spend any time on, complicated macular lesion. But this patient also looks like there's something going on temporally. We can now look here, and we can look at this in this is a 2-dimensional slide, here's a 3-dimensional slide. We can see the elevation of the retina. So this is all the neurosensory retina separated from the retinal pigment epithelium. The PIL is over here, and the PIL just comes all the way up with this tissue. So this is a frank retinal attachment. Definition of a frank retinal attachment, 9 layers of the neurosensory retina separated from the retinal pigment epithelium. And the vast majority of retinal attachments are due to tears, and the vast majority of retinal attachments have to be treated, whereas the vast majority of schisis conditions don't really have to be treated. Here we have a high myope, and we're sort of below the macula, but within the posterior pole, and we can see multiple splits within the retina. This is a retinal schisis, central retinal schisis, associated with high myopia. Not much in the literature on this, but they actually are fairly common. I'm presenting some of these, as I'll show you in a couple of moments, at ARVO in 2 weeks, because we have 15 of these cases, and none exist in the world literature, at least the ones around the optic nerve head, as we'll see in just a couple of moments. This one is still below the macula, and you can see splits, multiple splits within the neurosensory retina. The PIL is still intact, and the PIL corresponds to the retinal pigment epithelium. That's what it looks like in 3D. And there's the patient, patient's fundus. Okay, so now we have our 6 by 6 millimeter box, one slice right through the fovea shown here. We can see peripherally, temporally, it looks like 9 layers of neurosensory retina separated from the RPE. Over here, we're taking the slice very close to the bottom of the box, and now what we're seeing is a much greater separation. So here's the retinal pigment epithelium, here's the neurosensory retina, and here are folds within the neurosensory retina. That's typical of a retinal detachment, and that's what that is. It's a retinal attachment where the macula is still on, still a macula-on detachment, but can easily lead to macula-off detachment any minute because it's really so close. This patient needs needs surgery. So a retinal schisis will see multiple splits within the retina, whereas a retinal detachment will see 9 layers of the neurosensory retina separated from the retinal pigment epithelium. We should be able to make the differential diagnosis with OCT in virtually every case. We have that arrow someplace. There it is. Okay, again, retinal schisis above, retinal detachment below, and they do look different in 2 dimensions and in 3 dimensions. We have this on Retina Revealed, and we actually show the very nice movies of all this, but we're not going to play any of the movies tonight only because it's technically a little more complicated and just takes up time. But we do have all that on Retina Revealed if you want to see movies of this. Okay, here we have peripapillary retinal schisis, and this is truly a novel clinical entity. We see these in myopes usually 6 and above, and we've seen about 15 of these cases, and there's not a single one that exists in the world's literature, but we're presenting it next week. And you can see in this instance multiple splits at different layers. So here's a split we're taking a slice right above the optic nerve head, and we can see multiple splits. Here's another one. This is still a left eye. This is now a right eye up here, multiple splits in both eyes. So these splits are interesting. The question is, do they have any clinical significance? And we'll get to that in just a couple of moments. Here's another patient with peripapillary retinal schisis and high myopia. Multiple splits within the retina. And we can see what may be traction right over here. And in some of the cases, in about half the cases, we do have what we think is vitreoretinal traction. And if you have vitreoretinal traction, you may want to then consider doing something about it, if indeed this area increases. These patients may have enlarged blind spots, and when you watch them carefully, they actually can progress. So here's another patient with 3 slices, went through the top of the disc, went through pretty much the middle of the disc, went through the bottom of the disc, and we can see splits at all different layers. So peripapillary retinal schisis and high myopia is not that rare. This is the first one I've ever seen. This one goes back. This one was imaged on the original TopCon OCT, the 1,000, not the 2,000. 18,000 A scans per second as opposed to 27,000 A scans per second. So the images aren't quite as good. This is a very, very high myope. Right eye is -18. He lost his vision over the last month. It's down to light perception. And he has splits 360 degrees around his optic nerve head. Here we're just showing you one inferiorly. The reason I'm showing you that one is because here there's really good evidence that we have traction. So this is vitreal traction onto the retina, causing this elevation, probably causing the split itself. So you show this to a vitreoretinal surgeon, and they'll say, wow, I've never seen that before, but because I've shown it to a whole bunch of vitreoretinal surgeons. And they say, I can go in there and remove the vitreous and remove that membrane, and maybe the retina will flatten. And then if you do this in the other eye has to split only nasally, not temporally. This eye has reduced acuity. And the left eye actually shows 20/30 acuity. Both eyes have about -18 refractive error. Neither of these were picked up clinically. Couldn't see anything clinically. Here's a slice right through the optic nerve head. This is temporal in the right eye and nasal in the right eye. You can see both splits. In the eye that still sees, the split occurs nasally over here, but there's no split temporally. So whenever you get to see these high myopes, I think you should image the disc and the macula. And if you see a schisis, what you should do is search for traction. And if there's any traction, and if the patient does progress a little bit over time, I would see these patients very often, probably every couple of months, then you might want to consider doing a vitrectomy and a membrane peel. I don't think anyone's published it. I don't think there's anything in the world's literature on that. A couple of conditions look like this. This patient actually has sickle cell. We usually think of sickle cell as being a peripheral retinal disorder. This patient has some fibroglial tissue going on in the mid-periphery, causing also, this is fibroglial tissue, causing the retinal schisis. So you can get tugging of the retina or splits within the retina due to fibroglial tissue, which is secondary to some conditions such as sickle cell, or even diabetes, of course. That's certainly possible. Going back to a patient who has X-linked retinal schisis, so here through the macula, that's X-linked, and this patient will have a different electroretinogram, will be electronegative because of the Mueller cell abnormality, and you might see radiating folds in the macula. So we can usually make a differential diagnosis based upon age of the patient and based upon location. So all the retinal schisis are pretty interesting conditions. How about this one? This is a vertical slice through somewhere in the posterior pole. What the heck could that be? This case is also in Retina Revealed. We can look at it in grayscale as opposed to color. We can show you the fundus image, and we can show you, it might be easier to see this one. So this is a boat-shaped hemorrhage, if you will. It's a subhyaloid hemorrhage. It has a flat top because of gravity. And we're taking this vertical slice, and we can see right over here, this corresponds directly to where the blood is. I don't know if your monitor can pick this up, but there are a bunch of dots in here. These are red blood cells that have not settled yet. So this is the elevation. The reason why we're not seeing retina here is because the blood in front, which is probably taking up all this space, is reflecting and absorbing much of the light, and it's not penetrating. So we call this shadowing. And shadowing is a very common phenomenon in OCT, and it's something that we clearly have to keep into consideration, because it's something that can be somewhat confusing. And it looks like there's parts of the retina missing. But shadowing is something that you have to keep in mind. Whenever we see areas in the retina where things look like they're missing, it's probably something in front of it that's causing that to occur. Here's something growing off the vitreous, off the optic nerve into the vitreous. This is not a diabetic. It's sort of common in diabetics. It's more of a rare disease. We'll see some diabetics a little bit later. So if we take some images here, this patient, here's a slice right through, very close to the optic nerve, and we can see tissue growing right into the vitreous from the retina. Here's what it looks like clinically. And this is really proliferative retinopathy. So new blood vessels growing off the surface of the retina, off the surface of the optic nerve into the vitreous. So it's really like fibroproliferative retinopathy. This is not a diabetic. This patient has a fairly unusual condition. Diabetics can also present this way in almost a similar fashion. And this patient has something that we call IRVAN, which is idiopathic retinitis, vasculitis, aneurysms, and neuroretinitis. Sounds to be a young woman. She's like 23 with a 2-year-old son who has this idiopathic condition. When we say idiopathic, it's really a primary retinitis. It's not a secondary retinitis, not secondary to diabetes or hypertension or sickle cell. It's primary. These patients are worked up from head to toe. We can't find a thing wrong with them, and yet they have all these bizarre things happening in the retina. This is also in Retina Revealed if you'd like to get some more information about this one. So new blood vessels coming off the disc, fibroglial tissue proliferation, neovascularization of the disc, if you will. Okay, back to all our white dots and spots that we have to keep into consideration. What are those? Are those drusen? Maybe. Are those drusen? Maybe. Those are drusen. No, those don't look like drusen, but they could be. And how about those? Are those drusen? Well, OCT can pretty much give us the answer in all those cases. Even when we're talking about something as simple as drusen are now or can be described as being hard drusen or cuticular, and some of these hard drusen or cuticular ones infiltrate through the retina, as we'll see. We occasionally see, this is probably rare, I've seen this only a few times, and you have to really get high-quality images, subretinal drusenoid deposits. So these are like drusen, but they're a little bit different. They only sort of have soft drusen. So hard drusen, soft drusen, and something in between that we don't see too often, which is really in a slightly different location. It's not under the retinal pigment epithelium. That last one is actually under the neurosensory retina. And I'll give you one example of that and a bunch of examples of the common ones coming up. Okay, well here we have something going on in the middle of the retina. Actually, this is in the outer plexiform layer specifically. Are those drusen? Well, that's not where drusen hang out. Drusen don't hang out in the middle of the retina. Okay, and that blue, if you can see it, corresponds to the outer plexiform layer. We'll show you a histology again, so where outer plexiform layer is. It's right about over here, this zone over here. So when you get white dots at about that level, that's going to be something that's unrelated to drusen. Those are exudates. And exudates you can get in a lot of different conditions. Certainly diabetics have lots of exudates and hypertensive patients. So these are hard exudates, but they're in the middle of the retina. Turns out that many of them are invisible to ophthalmoscopy. So for example, here's an OCT horizontal slice. You probably don't see any exudates here. And right over here in the bullseye, crosshairs if you will, there is an exudate, which is below the resolution of fundus photography and of direct ophthalmoscopy. Those two have resolution abilities of about 25 to 30 microns. OCT has a resolution closer to 5 microns. So here we see some of these little tiny exudates. And we counted these, by the way, carefully with a 3-mirror lens. And we also counted with a fundus camera. And we're getting about, in this specific eye, in the central part of the retina, 6 by 6 millimeters, we counted 21 of the exudates. We then counted OCTs in 128 of the slices in that 6 millimeter zone, 6 by 6 millimeter zone, and we counted 405. The ratio was 20 to 1. So for everyone we saw clinically, there were about 19 that we missed clinically. This one you can see clinically. That one shows up. That's big enough to show up. The two next to those, still in the outer plexiform layer, don't show up clinically. We can now take a slice above, And in this entire slice, we really don't see any exudates. However, when we take that horizontal slice here and we count them, we have about 10 exudates in the outer plexiform layer. So overall, my sense is, and I've done studies on small numbers of patients, small number of eyes, sometimes the ratio is 20 to 1, sometimes it's about 10 to 1. But virtually, you always see far more exudates, these are the white spots in the central part of the retina, with spectral domain OCT than you will with an ophthalmoscope. If you take a diabetic after, say, 10 years and you don't see any exudates with an ophthalmoscope, don't be surprised if you do OCTs and you find some of these little white dots in the middle of the retina in the outer plexiform layer. In contrast, these are what drusen could look like. They could be, this is sort of a medium-sized drusen. Here's a pretty large one. Here's a very large drusen. Drusen are typically dome-shaped, and they're under the retinal pigment epithelium in the vast majority of cases. So the RP is elevated. Here's a normal control for comparison. As you get a larger and larger druse, the PIL above it becomes very attenuated, becomes more and more attenuated as a general rule. And why is that not going forward? Let's try it one more time. There we go. Okay. This is actually a three-dimensional movie that we're not going to play. This patient has lots of drusen, as you can tell. These are actually, most of these are soft drusen. Soft drusen is sometimes difficult to make a differential between PEDs. So this big one over here looks pretty much like a PED, but it's really, you're not going to get, hundreds of PEDs. But soft drusen are, somewhat similar to pigment epithelial detachments. We can look at it in grayscale. And you can see that as you get larger and larger drusen, the PIL becomes less obvious. And we're going to point that out in some other images in a few moments in some great detail. So here we have the same patient. We're just taking a bunch of different slices. So we can actually see PIL present over here. And then as we go over this large druse, most of the PIL is missing, which may tell us that that may be an area that doesn't see particularly well. This is a immunohistochemistry, this one above, or something similar to that. It's from a donor eye of a patient with a druse. And this is the retinal pigment epithelium. And here's Bruch's membrane. But that confuses us because that's the way histopathologists look at it. We don't look at it that way. So let's turn this thing upside down. So here's the druse, if you will, out of a donor eye. And here's the retinal pigment epithelium, which is over here. And then we have below it, here's Bruch's membrane. So these typically grow on Bruch's membrane and under the retinal pigment epithelium in the vast majority of cases. Here's a case where cuticular drusen, the small hard drusen, seem to infiltrate through, I call this infiltrative drusen, a word that's not used in the literature at the present time. But clearly you can see that these drusen are sort of eating through, or infiltrating through the retinal pigment epithelium, and also the PIL is pretty much very affected. So infiltrative drusen do occur unless these patients have a somewhat reduced acuities. You still see there's still some PIL left, but clearly it's not as if the PIL is just being pushed forward, which I'm going to show you in just a couple of moments. So that was infiltrative drusen. Here's a patient with some drusen, and we can see the PIL looks like it's intact, pretty much intact here, but certainly thinner than it should be. And right over here, it seems like it's sort of okay. And there's some little spot there that we don't really know. Here, we actually have the fundus slice which we're taking, and with some interesting spots there. I'll talk about that in a moment. In this eye, we're getting fairly typical drusen in the left, but in the right eye that we're going to show now, we're actually getting some things that are a little bit different. Rather than being under the retinal pigment epithelium, they seem to be above the retinal pigment epithelium. These spots over here, these are drusen-like, or subretinal drusen-like deposits. So they're under the PIL. See them over here? That's fairly unusual, but it does occur. We don't really know how often. Article published this week, this year, just a couple of months ago, by some people in New York from Larry Annuzzi's group. Rick Spade is a specific person that noticed this first and published this major article. So we're now calling these drusen-like deposits, this sort of subretinal drusen-like deposits, instead of being just under the retinal pigment epithelium. So you can actually have them in the same eye. You can have some of the drusen. This is sort of one typical under the retinal pigment epithelium. You can see the PIL above it, right over here. PIL still intact right over here. And just for the differential, this one over here, some more white spots here and some over here. These dots are within the central of the retina, central part of the retina. So what does that mean? Well, here's a statement. With spectral domain OCT, we can confidently make the differential diagnosis between exudates and drusen 100% of the time. And that's true. You see dots, you see some dots in the fundus, and the two most common causes of dots, we talked about some that aren't common, but drusen and exudates are common. 100% of the time you'll be able to make the differential. And that's actually important. The patient below, you may want to do genetic testing for MAC to gen. We'll talk about that in a couple of minutes. The patient above, you probably want to work that patient up for systemic disease. So you can clearly tell the difference in 100% of the time. And this is one of the reasons why 100% of optometrists and ophthalmologists should be using this technology, because it helps in so many ways to come up with the correct diagnosis. Spectral domain OCT is really dramatically useful. Here's a left eye of a patient, and first question is, what's the visual acuity? The way we interpret visual acuity, or in a sense, guess visual acuity, more than guessing, we predict it. Here's a foveal pit. We want to look at the PIL under the foveal pit, and the PIL is intact right under the foveal pit. This patient has 20/20 visual acuity. However, there's an area right over here where the PIL is missing. And then we're actually getting some of the retinal pigment epithelium missing here. And then we have that very thin, narrow band that we talked about before, which is Bruch's membrane. We now have that same spot. We're taking a horizontal slice through it as opposed to a vertical slice that we did before. So right over here, as you can see, that horizontal slice corresponds to this. This vertical crosshair corresponds to this. So the PIL is present, 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 whoops, present, present, and then it ends right about over here, and it comes back. So where it's missing, where there's no photoreceptor integrity on, we're also missing pretty much all of the retinal pigment epithelium. And then we have Bruch's membrane here, which is sort of unmasked. We can still see it, because the RP is missing. So this is not a drusen. This may have been a drusen, but right now that corresponds to an area of what we call geographic atrophy, a small area of geographic atrophy of the retinal pigment epithelium. Now, since the photoreceptors are missing, you might say that if we can get a visual field of that little point, that spot, we're going to have a reduced visual field. Well, it turns out we can do that in this day and age. We have microperimetry, and microperimetry with the Maya system, which I've used now for the last 4 or 5 months, find extremely useful. We did a typical Meyer on this patient, and we're getting one red dot. The green are all normal, but there's one little point here. So it's a visual field test where we're actually monitoring fixation. Whoops. We're monitoring fixation 25 times a second. So it's a standard visual field, or not a standard, but it's an automated visual field system. It uses an infrared scanning laser ophthalmoscope that allows us to look at the retina. And it takes images like this 25 times a second. And that's an automated eye track, and it allows us to always put the stimulus in the appropriate place, because we know precisely where the vessels are, we know precisely where the eye is, it's tracking the eye, and we can actually do reproducibility studies of separate points and show that it can always stimulate the point you want to stimulate. You can also go back and test the patient a week later, a month later, a year later, and you can test the exact same points again. Let's say, we'll take the same image of the fundus, the scanning laser ophthalmoscope image, and match it up, and then test the areas. So here's one of the standard one of the standard visual fields we do with this instrument. And notice, green is normal sensitivity. It's usually about 28 to 32 decibels. Yellow is slightly reduced sensitivity, as you can see, in the 20s. But there's one point that's dramatically reduced over here in red. That point corresponds to this point here. So that point doesn't see. That's very reduced sensitivity at that point. We can then put all this together. We can look at the OCT and say, gee, the PIL is missing, the photoreceptor integrity line is missing. That corresponds to this area here. And then we can actually do a specific test. This is a custom test, but what I did is actually I clicked that point twice. I was able to get 2 stimuli right within that point, and then I clicked stimuli around it. I clicked the areas of the retina around it. And you can see what actually happened right over here. I think we have one more slide of that, which puts it together. And over here, we have that horizontal slice right through that area where there's tissue missing, this small area of geographic atrophy of the retinal pigment epithelium. I was able to click that twice on the scanning laser ophthalmoscope image, and you can see those 2 points have extraordinarily reduced sensitivity. The points around it have fairly normal sensitivity in green and somewhat reduced sensitivity in yellow. So drusen, you can figure out, you can actually measure the sensitivity of individual drusen. And I'm starting to do that pretty much routinely now on, on certain patients that are very interested. I saw a patient today who happens to be a physician, a rheumatologist, and he has a bunch of drusen. And he wants to know, he's like 43 years of age, and he said he wants to know he's going to go blind. So we did a whole series of tests on him today. Very interesting. We were actually able to monitor his, you can see his PIL in most places over his drusen. Here's another patient with geographic atrophy. Here's a vertical slice. You can, again, predict what the acuity is. Right under the foveal pit, we have tissue. So that's the PIL. So this patient probably has 20/20 acuity. He does have 20/20 acuity. Then below it and above it, the PIL is missing. So if you did AMSA grid, this patient would see the center, but then would see things missing above and below. Or a central visual field. I didn't test this patient on the Maya yet, the microperimetry test. That will be interesting if I can get this patient back for that. This patient goes back a little bit. But this is geographic atrophy. Geographic atrophy is dry mac degen, but associated with 20% of substantial vision loss in patients with mac degen. 80% of patients that have less than 200 acuity have wet mac degen, but 20% actually have geographic atrophy. This is a 33-year-old. This patient is 33 years of age. Interesting history, a drug addict, and she said she had terrible nutrition for 2 years. We're not sure if that relates at all, but she has a fundus that's filled with drusen. And we tested her sensitivity. We did put her through a Meyer. So here we go. Whoops. Let's go back. Here's a slice in this patient. So we dotted that drusen. We dotted all these drusen, as you can see. And we can actually measure the sensitivity. So let's take this horizontal slice through the fundus image. We can look at that same slice, not quite horizontal, it's on a slight angle. Red corresponds to red. The red circle corresponds to red circle. She has 20/20 acuity, by the way. So right over here is her foveal pit. She does have tissue, a PIL under her fovea, so she still has 20/20 acuity. And even above this druse, which is shown here in this red dot, you can see that the PIL is still intact. So in this instance, the retinal pigment epithelium is being pushed forward because of the presence of the druse below it. But the PIL, photoreceptors, is still intact. And that gives us a sensitivity of 30. So that point, she still sees with, thank goodness. Then we have this blue one, where it looks like the PIL is still present here, less well-defined here, comes back. And over here, you'd expect a little bit of a reduction in sensitivity because the tissue is not quite as well preserved as it is over this drusen, that specific drusen. And you can see the sensitivity is a little bit reduced, like 26 decibels. So a difference of 4 decibels between the two. So we can actually, in this instance, we've actually tested all those points, as you can see, and we try to get OCTs through the same points. This becomes important when we start treating patients, either nutraceutically or with some of the new drugs that are about to be released that some of us have been hearing about for dry mac degen. So OCT is useful, but also microperimetry becomes extremely useful. Here's the left eye also. In comparison, here we can see a PIL, which is present, somewhat impaired, but present over the drusen, and the sensitivity is 28 microns over there, still pretty normal. So yes, you can figure out sensitivity of individual drusen. Now, one of the problems, of course, with dry mac degen, drusen degeneration, is 10% of patients with dry mac degen go on to develop wet macular degeneration. So here's a patient above that had those sort of cuticular drusen that we talked about before that looked like they were, in a sense, eating through the retina. They were infiltrative as well. And then this patient developed a bleed, choroidal neovascularization, with blood and with some exudates, as you'll see in a moment. The patient was unaware of it because it didn't occur in a central 5 degrees. So completely unaware of it, just came back for this patient's routine 3-month exam. And sure enough, the patient has wet mac degen. We did a fluorescein. Wasn't particularly helpful, but we were able to, this patient has been treated with anti-VEGF medicines. This patient, is under treatment. And I can't really give you any, I can't really tell you how it turned out quite yet. It's early in the process. I'm just trying to find one specific slide if we could. So here we're taking different cross sections. Here we have one. So here's a horizontal slice, okay, through this stuff over here. And if you notice, you may have not, but these white spots weren't here before. in that last image. So here's bleeding, of course. And these are, we think these are actually exudates. These are drusen, these are exudates. How can we tell? Well, they're obviously going to be at different levels based upon our previous discussion. So the section right over here corresponds to this. So those are in the middle of the retina, in the outer plexiform layer, if you will. Those are exudates. These are drusen, infiltrative drusen, sitting right on what we think is Bruch's membrane right over here, that very narrow band going across. So he's being treated with Avastin, which would be typical. If you prove it, you don't really have to prove it with fluorescein. You don't really need a fluorescein. We did it anyway, but it didn't, it didn't show his corneal vascularization under it because there's too much blood. There are too many things. So the patient has a thickened area here below the macula in the arcades, and there's clear fluid, blood here, serosanguinous fluid, if you will, and exudative deposits. All these little white dots are exudates. So we wish this patient well. Macular degeneration is obviously a big problem. In patients over the age of 65, it's a leading cause of blindness in the United States. And now we're getting some drusen, maybe, and all these different conditions. And again, OCT can tell us levels and help us with the differential between all of these. So it really is extremely useful. How about this patient? This is an optometrist friend of mine, age 59, lots of tiny little drusen. I hope you can see those. Also, this patient in the peripheral retina has drusen, and those drusen in the peripheral retina we picked up with Optomap. The problem in this instance is she has a father who has disciform macular degeneration. So this OD at age 59 has drusen, and she has a dad who has disciform macular degeneration with acuity about 2,800 in the sun. So what is her chance of getting her dad's genes? Is AMD in your DNA, if you will? So AMD, age-related macular degeneration, is a genetic disease with known markers accounting for 70 to 80% of the population attributable risk. So what can we do about that? I took my colleague, this female 59-year-old optometrist, and I said, well, let's do the macular risk test. Let's get some cells from your inner cheek on both sides. We're going to put them in a FedEx envelope. We're going to send them out to a lab, and 2 weeks later, we're going to find out what your risk is of developing macular degeneration. Well, when you get the results back, patient falls into one of 5 categories: macular risk 1, macular risk 2, macular risk 3, macular risk 4, macular risk 5. Normal risk is at a 10% level. So if you look at the entire Caucasian population, about 10% will develop macular degeneration. So that's fairly typical for macular risk 1. Our patient, our optometrist friend, is actually in macular risk 1. She only has a 3% chance of going on to have progressive loss from her early AMD, she has drusen now, to advanced AMD with vision loss. Only a 3% chance based upon her genetics, which means she's gotten some good genes from mom. Her dad has macular degeneration wet with a big giant disciform scar. Her mother, at age 95, still does not have macular degeneration. About 20% of the population fall into macular risk categories that we feel should be looked at very, very carefully. So what I do is patients who fall into macular risk 1, I see them about once a year. Patients, say, who fall into macular risk 3, I see them 3 times a year every 4 months. Somebody's in the macular risk 5 category. They have a 73% chance, average of a 73% chance of progressing to advanced AMD with vision loss. So these patients want to see 5 times a year. And I think I have the justification for seeing the patient that often based upon what we know about the genetics. We just gave a major talk over the weekend in Connecticut. We called it the AMD Center of Excellence, so building such an AMD Center of Excellence. We went through all the technologies, and of course OCT was a major part of it. And on the program with me was Michael Tolentino, who you can see here. And he spent about 10 or 15 minutes on what he knows very, very well. And he's sort of a biochemist in addition to being a retinal specialist, trained at Harvard, very smart guy. And he's one of the people that think that carotenoids are actually very, very important. But specifically, and this patient was, this article was published 4 weeks ago in the Review of Ophthalmology, March 2010, and it says targeting AMD with a critical carotenoid. It was by Bone, Landrum, Beatty, and Nolan. These are the 4 leading people in the world in macular protective pigment. And what they're saying is there's a critical carotenoid, and they're saying the critical carotenoid is mesozeaxanthin. So Michael Tolentino says that we really want to, these are the carotenoid triplets, if you will. You should treat patients with lutein, zeaxanthin, and mesozeaxanthin. And meso has been proven to be the key carotenoid in the fight without against AMD, and that's his point of view. But there's really research out there now that's suggesting that really the key one is mesozeaxanthin, but you really need all three. There are no contraindications at all to taking meso, and meso is actually a dominant macular pigment in the center of the fovea, and there's some studies on that were mentioned by Bone, Landrum, Beatty, and Noland. So this is really the way to go. Well, it's one of the products out there, Macular Health, that has all three of the carotenoids, or the triple carotenoids, if you will. Okay, going back to dots, we have dots in other disorders. Also, this is one that's fairly rare. In this instance, this patient has something called fundus albipunctatus, which is a congenital, non-progressive form of night blindness. So it's CNBD, congenital night blindness, congenital stationary night blindness. These patients have lots of dots. Those dots, by the way, when you look at them on OCT, are at the level of the PIL. The PIL is not normal, but they're at the level of the PIL, and they sort of straddle the PIL. So these dots are typical on OCT patterns, and we published this in Retina Revealed. They seem to straddle with the position of where the PIL should be. So you can make this diagnosis just with OCT. Okay, going back to what I showed you before, again, those are the dots associated with central serous, which we call those the edema residues or retinal precipitates. But those, you're really not going to get confused based upon what we see with OCT. How about this myope, a student of mine? She's a 7th myope in both eyes. She has 20/20 visual acuity. Here's her left eye. We're taking a section above the macula here and a section below the macula here. And although her fundus looks normal, she actually has this, which looks like a mini bulge, 2 mini bulges. Is this the earliest sign of posterior staphylomas? Could be. And when we look at this, when we look at the retinal pigment epithelium, we separate it out, just segment it out, we can see these 2 bulges right over here. So these mini bulges are highly characteristic and maybe pathognomonic as the earliest sign of incipient myopic staphylomas. It could be there's another condition, and actually this patient with 2 eyes is included in an article I just wrote with a bunch of people will be published real soon. It's being called choroidal ectasia. But in reality, all the patients were myopes, and I think we don't have long-term follow-ups yet. But all these mini bulges may be aborted areas of staphylomas where they actually could lead to staphylomas. So there's not much you can do for these high myopes, but I do try to make sure that the pressures aren't elevated because there's some evidence in the world's literature that spikes in intraocular pressure occur more often in myopes, and that can actually cause these mini bulges. That's something to consider. Nutrition analysis is something else we would consider in these patients. Okay, here's a typical image that many of us have seen numerous times where the vitreous looks like it's tugging on the macula. So this is vitreal macular traction syndrome. The architecture of the macula is obviously abnormal. The PIL is still intact in this instance, and a certain percentage of these patients will develop a macular hole. But often this just separates all by itself. If you have a macular hole in one eye and you develop one of these in the second eye, the question is, what do you do? Maybe you go in and do a vitrectomy and a membrane peel, because that may make sense, because maybe a third of these patients go on to develop a macular hole in the second eye. Although this is well known, these vitreal macular traction syndromes, there's another condition that's not known at all, and these are vitreal papillary traction syndromes, where the vitreous is actually tugging on the optic nerve end. This is a specific patient seen by a colleague of mine. Patient's age 59 or so, and the patient came in complaining about slightly reduced acuity, had an enlarged blind spot, and you can see this tugging on the macula. Now this was interpreted as being anterior ischemic optic neuropathy, and the patient was worked up for everything under the sun, autoritic, non-autoritic, also they did MRIs on this patient. Everything came back normal, and then after the MRIs were normal, I actually got to see the patient for the first time and did an OCT scan of the optic nerve, and you can see that there's clear traction on the disc. So not only do we have vitreal macular traction syndrome, which is well known, we have vitreal papillary traction syndrome, which is not at all well known, and I don't think is the case in the world's literature. We did put that in Retina Revealed about a month ago, so it does exist now. And as we can see here, traction onto the optic nerve head from the posterior hyaloid. And it's sort of very similar to what is vitreal macular traction syndrome. Other things that occur at the level of the optic nerve head, as we're showing over here, this is actually something that's very common, and about 73% of patients have this, and it's just a congenital anomaly, Bergmeister's papilla, if you will, coming out of the disc. Clinically, you don't see this. I've looked at 50 students of mine, 100 eyes, found it in 73 eyes, 73 out of 100 with spectral domain OCT, and I couldn't see a single one clinically. So clearly it's below the resolution of the direct ophthalmoscope. Here's a patient with a blurred disc border. Again, we would get concerned about this, possibly think of papilledema, papillitis, or something like that. This one happens to be bilateral, except that this patient has a clear, obvious druise, so there's a disc drusen. This gave me the opportunity of finally learning what disc drusen do to OCT, or how OCT interprets these. So here we have that disc druise. Here we have sort of an autofluorescent image taken with the filters of the standard 3D OCT 2000 Topcon system, and that corresponds to this. We can go a little further in the left eye, and then also look at this pseudo-autofluorescent image, if you will, and those highlight. You can see those correspond. That's really the same size, so you're going to see 2 of those at least when we actually start to do the OCT. So patients with disc drusen have elevated disc borders, but so do patients with papillitis and papilledema, so that's not helpful in the differential diagnosis. What is helpful in the differential diagnosis, somewhere down here, is this. Okay, we're actually measuring the retinal neurofibrillary thickness. First time tonight we're talking about that, but we can see the neurofibrillary thickness below is clearly great, 189 microns versus, say, 91 above. So we'll keep that in mind. By the way, if there's going to be a field defect, you would anticipate the field defect will be inferiorly, based upon the fact that the neurofibrillary is thinner superiorly. Okay, so there's a disc druise. Obvious disc druise. We'll get it into the crosshairs of the OCT, and that's what a disc druise looks like. In this instance, it looks like it's oval. It would be round if we used a one-to-one dimension on the OCT, but we usually, in a sense, increase the dimension in the z-axis on OCTs in order for us to see more tissue. But that's what a druise looks like. That corresponds to this. Okay? So it's a hyporeflective spot, different than what you may anticipate, because most of us who've learned ultrasound recognize that on ultrasound it's going to be exactly the opposite. Here's another disc druise here, which you don't see clinically, but it shows up here on OCT. So what we did is take one disc druise that's very obvious clinically. We can see it with an ophthalmoscope with a fundus image, fundus camera, looked at it, did an analysis on it, and now we think we know what to look for in other patients or in other areas of the disc. So let's blow this one up. Here's the other eye. So this one is a disc druise, probably not at all obvious to you, but it corresponds to this oval right here. And there's still another one over here that we can see. And there you can see, right in the center of the crosshairs, that corresponds to that. So if you have a patient with blurred disc borders and you're not sure about the disc druise, and ultrasound may help, but OCT should also help. You should be able to pick these up on OCT. So that's exactly what they look like. So they're not hyper-reflective as you might anticipate, because that's what ultrasound shows. They're actually hypo-reflective. And by the way, we talked about the retinal neurofibrillary being thin superiorly. That's why we have this inferior field loss in both eyes. And ultrasound does show it, again, with ultrasound we're getting an increased echo with ultrasound, which is exactly opposite of what we get with OCT. So that's important to keep in mind. Next case, and I think we're getting close to the end. This patient has some interesting, sort of hills and valleys at the level of the retinal pigment epithelium and the PIL. Now, what do you think that might look like clinically? Here is a vertical section, and that's what this corresponds to. And we can see that there are these lines going across horizontally. This patient has choroidal folds. And choroidal folds are problematic because choroidal folds may be due to to a mass in the orbit that's compressing the globe, causing the choroid to be set into folds. Here's the left eye of the same patient. This patient actually has congenital disc anomaly with disc drusen in addition. And these are just very interesting discs with vessels, but it's all congenital. And I actually think that the horizontal choroidal folds are also congenital. Patient's mentally retarded and has a bunch of other problems. But the concept of being able to pick up choroidal folds with OCT is actually extremely helpful. It can make the differential diagnosis between choroidal folds and something common like an epiretinal membrane. Epiretinal membranes we don't get too concerned about, but choroidal folds due to the presence of a mass in the orbit is very problematic. Okay, going back to a diabetic, here we're taking some sections right through the optic nerve of the diabetic. We'll do this quickly. And we can see we have here this patient had neovascularization of the disc. And what we're seeing here is now a traction retinal detachment. This is the vitreous tugging on the disc. And you'll see down here that the retina is actually detached in certain spots. This is actually a fairly common finding in advanced diabetics. Traction retinal detachment shown right over there. The retina is being tugged up. And here's the vitreopapillary traction, if you will, from new vessels growing off the surface of the disc, replaced with fibroglial tissue growing into the vitreous and forming a relationship with the posterior hyaloid. Many of these images, and these all exist on Retina Revealed, under one of the cases of diabetes. So this is RR number 16.
Great. And Dr. Sherman, I'm going to have to actually cut you off. Maybe we have time for one more case. And
okay, so do you want to, well, you can cut me off, or we could take questions. I'm sure, tell me what's best.
Okay, well, we have 5 minutes before the software actually kicks us out. So, you know, before we even take questions, let me just remind everybody, if you have questions and we don't get to them, visit ODWire, go to odwire.org, click on the Webinars tab, and this webinar will actually be the first one that comes up. And you can ask questions there, and we can continue the conversation about the presentation there as well. And the archive, the video archive of this webinar will be up within a couple of days as well. So if we get cut off here during the question section, just come back to this so you can continue the conversation. But let me just get to a couple questions maybe. So the first question is, how does OCT compare in early glaucoma detection compared to HRT or GDX?
That's a very, very good question. If you're talking about the peripapillary measurement of the retinal nerve fiber layer, I think GDX generally does a better job. I think, in general, nerve fiber layer technology is better than HRT. Looking at the cup size, the number one reason that patients have large cups is that they have physiologic cups. So HRT virtually never makes a diagnosis on the first visit. You have to look at the patient over time. If I had, and I do all these procedures still on all glaucoma patients that I see, both at SUNY and in private practice at the Eye Institute. I think the GDX is actually the best. OCT is helpful. If you look at Retina Revealed, one case back, there's one that was just released today or will be, but one case back, we compare circumpapillary retinal nerve fiber layer measurements with OCT to GDX and also to microperimetry, and also to another new concept which is called ganglion cell complex. So that's in Retina Revealed, I think it's case number 34, where the comparisons are there. I think that will be very helpful for you.
Great. Okay, another question here. The Plaquenil OCT screening tests, are they reimbursable?
There's a code that you can use for Plaquenil toxicity workup, and that usually includes pretty much everything. And my recollection is, I mean, in our office, I've never been told that it's been turned down. So I think Plaquenil toxicity testing will cover OCT. Certainly covers 10-degree fields, and it certainly covers fundus photography.
Great, and we have time for one more question. Sure. We have time for one more question. Do you have any comments regarding the different qualities of the various OCTs that are available on the market?
Well, I've looked at all of them, and they're actually they're quite similar. There's not that much of a difference between them. The Heidelberg is the most expensive, and it may take the longest to do. That may be, you might want to argue that has the possibly the best resolution. The cheapest on the market at the present time is the OptiView, the iView, and that one surprisingly actually has quite good resolution. I can't say anything negative about any of them. They're all very, very good systems. I think you have to decide what you want with the system. If you want a system that does everything, then you go for the $140,000 Heidelberg, the Spectralis, which does fluoresceins in addition. The cheapest is the iView, which is actually a good system. I happen to like the Topcon a lot. One of the reasons I like the Topcon a lot is because I'd like to be able to go back and forth between the fundus image and the OCT. I find that to be extremely helpful. Like this one right in front of us, this patient has a chirpy lesion. Why? We can look down here and see we're getting, as you can see, the level of the retinal pigment epithelium is hyper-reflective. The PIL is missing over here. The retina is attenuated. So I really do like going back and forth between a fundus image and an OCT image. I find that to be particularly helpful. The Cirrus device system is great also. They're all really great systems, but you have to decide what you really want.
Right. Great. All right. Well, I guess we're out of time. Dr. Sherman, thank you so much for your time and sharing all of this wonderful clinical data with us. And hopefully you'll come back to ODWire because I'm sure people have a bunch more questions. There's a whole list of them here that we're not going to get to. But thanks again, and thanks to TopCon for sponsoring the webinar tonight. And I hope to see you and everyone else back on OD Wire.
Well, thank you very much for giving me the opportunity, Adam. Take good care.
Great. Thanks a lot.